Today, the topic of our today's lecture, the basic syndromes of the patients with stomach and intestine diseases. We'll talk today about abdominal pain, gastrointestinal bleeding, dyspepsia, disturbance of gastrointestinal motor function, irritative bowel syndrome, and malabsorption. Abdominal pain, more often problems of the patient with gastrointestinal tract and all digestive system diseases. Patient come to you with pain into the abdomen. You must decide what is cause of this pain. For this purpose, you must distinguish visceral pain, which appears due to affection of abdominal organs, parietal pain, which appears due to involvement peritoneum in pathological process, and oftenly it is surgical pathology, which is called as acute abdomen and needed emergency aid. A referred pain of which appears in other side of the body, but due to crossing innervation will be felt of the patient as abdominal pain and must be differentiated with pathology other organs. Psychogenic pain, more difficult in differential diagnosis because pathological foci localizes into the central nervous system and patient feels pain without connection with any organic pathology. And extra abdominal pain, sometimes pain from the other organs which far from the abdomen may be felt of the patient as abdominal pain and must be very carefully differentiated to clear true pathology and give the patient helpness in time and correctly. Let's give characteristic every type of the pain. Visceral pain. I said you each is pain which appears due to true affection of abdominal organ. It may be sharp, acute due to spasm of the non-strained muscles or hollow organs. Such pain is more characteristic for affection of stomach, intestine, gallbladder. Pain appears due to sprain of the hollow organs wall and tension the ligamentous apparatus. It may be result of splanchnoptosis. Sprain of the parenchymatous organs capsule due to the distension, which is characteristic for liver and pancreas pain. Ischemic or stagnant circulatory injury in the abdominal cavity vessels. Such pain is more characteristic for acute intestinal obstruction due to obstruction of the intestinal vessels and as a result manifested with severe abdominal pain. Ischemic pain may be due to spasm of the vessels or due to the nervic stenotic process due to pathological growth of connective tissue. It may be result of complication of post-operative scar or any other pathology. We must remember about structural changes and organs injuries. Pain which appears after trauma, for example, and sometimes very difficult to decide abdominal organs involved in pathological process or no. If we are talking about visceral pain, you must remember that pain has definite location and obligatory has irradiative points. It spreads in other sides of the body because visceral organs has the same innervation with superficial tissue. We are talking about viscerocutaneous reflexes. And if you remember, they have specific characteristics for pathology of pancreas, gallbladder, liver, and other abdominal organs. Visceral pain tightly connected with functional activity of organs and accompanied with other symptoms which show pathology of definite organs, on which we'll stop later. Parietal pain appears due to involvement peritoneum into the pathological process. On contrary from visceral pain, it has local character, especially in first time patient clear show point of his problems. Parietal pain may be revealed with specific syndromes, for example, Schottgen-Blumberg syndrome, syndrome of irritation peritoneum. It can accompany with some symptoms which are not characteristic for affection of visceral organs, such as fever, progressive weakness, cold sweating. Sometimes patient can lose consciousness, and other symptoms of vegetative and central nervous system, which indicates about acute situation. A referred pain, pain which appears due to crossing innervation or same innervation of some inner organs. And sometimes we must differentiate a pain in upper part of abdomen between liver, gallbladder, stomach, and transverse colon, because they have approximately same level and same innervation. And sometimes pain from transverse colon will be felt of the patient as stomach pain. Patient cannot differentiate through liver or gallbladder pain and needed some doctor's knowledge to do differential diagnosis. Psychogenic pain. No, if you see on this picture, I want that you remember a psychogenic pain, pain which is formed into the central nervous system due to some psychic or mental disorders, and on contrary from true organic or visceral pain, it's very rich with vegetative symptoms. Patient give full characteristic of his problem, but you must pay attention that very often it's accompanied with non-adequate behavior of the patient, non-adequate face appearance, because when we'll continue examination and palpate the patient, his reaction non-adequate reaction of abdomen on your palpation, or reaction from inner organs which you examine during deep palpation. And extra-abdominal pain, extra-abdominal pain. No, we said last lectures, we said with you about a typical abdominal type of the myocardial infarction, when the patient instead pain in the heart region due to necrosis of the bottom of the heart, its lower part, feels pain in upper part of abdomen, and sometimes it may accompany with vomiting, with other symptoms of digestive, which is characteristic for digestive system, and sometimes patient hospitalized in gastroenterological department or infectious department except cardiovascular. We remember about pleural pain, yes, due to again same innervation of this part of the organ. It can sometimes instead pain in the chest field of the patient as a pain upper abdominal part. Very often needed differentiate pain from the kidney with liver and spleen pain, or sometimes pain into the large intestine, because sometimes in renal colic pain irradiates downward and patient cannot differentiate pain from the abdomen or pain from the loin, and needed very high attention of the doctor to establish true pathology. No, you see, as more questions are needed at the patient to clear origin of the pain, but I would pay your attention on main questions which are obligatory. If we are talking about abdominal pain, and first of all will exclude pathology of digestive organs, first of all we must clear position, character and radiation of pain. It helps you differentiate organ hollow or organ parenchymatose. Depending location also we can clear each is more characteristic for some or other organ. Then obligatory will clear of the patient specific aggravating or relieving factors. Factors which provoke pain, why, after what pain does appear. And if we are talking about digestive system, obligatory clear connection of the pain with eating and defecation. It also helps you differentiate, for example, stomach and transverse colon problems. Now let's see on this picture. You remember about topography of abdomen, which divided approximately on 9 parts, which is characteristic for any organs. And you understand if the patient feels problem in right hypochondrium, first of all we seen about liver, gallbladder, remember about head of pancreas and duodenum. Epigastria propria, more characteristic for stomach first of all, but we remember about pancreas and transverse colon. Left hypochondrium, maybe large cavity of the stomach, tail of pancreas, transverse colon and spleen. Right flank, ascending colon. Left flank, right flank, descending colon. Center of abdomen is more characteristic for small intestine and ilioinguinal region, right cecum, left sigmoid. Sometimes, first of all, we'll orientate upper, medium and lower part. More each upper part you see as more organs localizes in this area. Medium part, first of all, for problem with intestine. Lower part will do differential diagnosis between digestive organs and urinary tract and gynecological pathology for a woman. Now let's very fast remember specific characteristic of the pain, which helps distinguish pathology of any abdominal organs, because on exam when you will answer this question will obligatory ask you, for example, your patient with pathology of the stomach, explain please specific characteristic of this pain. No, first of all, stomach pain localizes in epigastrium region and irradiates backward. It's tightly connected with eating. It may be before and disappear or after eating. Tightly correlated with characteristic of food and accompanied with dyspeptic syndrome. I'll remember you, dyspepsia is disordered digestive process due to disturbed digestion and evacuation of food. If you see on this patient, we can pay attention on specific first posture. Pain really disappears or becomes less when the patient incline upward to separate stomach from solar plexus and decrease its irradiation. And sometimes patient may be lying position but also bend knee to the abdomen. Intestinal pain. I said you, we distinguish small and large intestine. Small intestine, center of abdomen, and patient show his problem. Large intestine, lateral parts of abdomen. On contrary, maybe same character, acute sharp spastic and dull distensional, but on contrary from the stomach, it's tightly correlated with defecation and passage of gas, and only transverse colon tightly connected with eating, because when the food falls into the stomach, it's pushed on transverse colon and simulate pain into the transverse colon, which assessed of the patient as stomach pain. But on contrary from stomach, it's also correlated with defecation or passage of gas, which is not characteristic for stomach pain. If we are talking about gallbladder pathology, pain localizes in right hypochondrium, but not whole hypochondrium, local, nearest rectus muscles, position of the gallbladder. It's radiate upward to the right. It may be acute, sharp, spastic, and dull distensional, and accompanied with some specific dyspeptic system as beta test in mouse, beta eructation, discomfort after eating of fatty food. Liver pain, also right hypochondrium, but depending size of organ, pain more diffuse. Patient put whole palm on right hypochondrium and sometimes to epigastrium because right and left lobe. But on contrary from gallbladder, maybe only dull pain because it is parenchymatous organ. It's also accompanied with some dyspeptic discomfort, especially after eating fatty food or taking alcohol, but it's more rich in its characteristic because liver is vital organs and except digestive system take part in other metabolic process. Pancreatic pain. Pancreatic pain can filter in upper part of abdomen from right to left hypochondrium, depending site of the pancreas, which involved in pathological process. It's radiate upward to the left, which help differentiate it from biliary tract and has specific Godlin character, which not characteristic for any other types of the pain. You see specific for posture of the patient, and patient explain, I feel a caudal constrict upper part of abdomen. And I'll again remember you this picture, which I think help you remember specific features of pancreatic pain and differentiate it from other abdominal organs. Godlin character only for pancreas due to its specific innervation. I'll pay your attention on dangerous or red flag symptoms, which must pay attention of the doctor on this group of the patient to exclude acute surgery pathology and prevent death of patient. For usual chronic pathologic gastrointestinal diseases, not characteristic severe weakness, apathy, giddiness. Problem with cardiovascular system such as decreased blood pressure or tachycardia. Visible hemorrhage, hematemesis, bloody vomiting, or blood during defecation. Fever isn't usual signs of chronic gastroenterological diseases. Sharp increase of the abdomen size. Repeated vomiting without positive effect, because it indicates about its central or toxic character. Absence of passage gas or peristaltic sound during auscultation of abdomen. Abdomen unaudible, and on inspection it can be unmovable, doesn't take part in breathing. Pain intensified. On palpation, you reveal exhaustion of the abdominal muscles. In this case, you obligatory check Schottky-Bloomberg symptom, and sometimes patient can lose consciousness during defecation or vomiting. All these symptoms indicate about acute abdomen, which needed emergency, sometimes surgical aid, because may be dangerous for the patient life. Diagnostics. No, first of all, for every groups of the patient, we'll start examination from routine blood and urine analysis. Depending on our primary opinion, we'll prescribe some biochemical tests for liver, for pancreas, for intestine. Then we'll send our patient on instrumental examination. If upper part, stomach, duodenum, fibrogastroduodenoscopy, ultrasonography for liver, gallbladder, pancreas, X-ray examination in case of acute abdomen, it's primary examination, which obligatory use in surgical department. We can send our patient on computer tomography if we seen about possible new growth and will find its source and clear presence or absent metastasis. Electrocardiography, obligatory for every patient after 40, sometimes 28 years old. We remember about the typical abdominal type of myocardial infarction. And if woman, obligatory diagnostic test for pregnancy, because maybe a typical extrauterus pregnancy. It is general diagnostics way which widen it after results of primary examination. Gastrointestinal bleeding. First of all, we are interested about bleeding from digestive apparatus, from esophagus to rectum, and will obligatory differentiate from upper or lower section of gastrointestinal tract. Pathology, which is provoke factors of bleeding. No, if the bloody vomiting, first of all, will exclude varicose veins of the esophagus as manifestation of portal hypertension, complication of liver cirrhosis. We must remember about Mallory-Weiss syndrome, specific rupture of the esophageal vessels. We remember about acute hemorrhagic gastritis or peptic ulcer and cancer, which is upper part, and Crohn's disease, which affect all intestine from small to its final part and may be manifested with bleeding characteristic upper and lower part also. If we are talking about lower part, more often provoke factors of bleeding is diverticulosis or neoplasm. We must remember about non-specific atherosclerosis, which affect only lower part of large intestine. We'll examine anorectal region to reveal problem with anus and hemorrhoidal veins. More difficult questions on exam. Where is border between upper and lower part of gastrointestinal tract? Border, medium part of descending colon, all above upper part. Bleeding invisible more often and revealed with special chemical test or special examination. From the medium part of descending colon, sigmoid and rectum, each lower part, which visible and patient can come to you with visible blood during defecation. But when we examine patient with bleeding, we must obligatory remember about some cardiovascular pathology, systemic diseases, and blood diseases, which also manifested with gastrointestinal bleeding, but cause of bleeding is affection of other system, and our primary therapy must be directed on correction of this problem, because gastrointestinal bleeding appears as complication but not as manifestation of main disease. Let's stop on the signs of the gastrointestinal bleeding. Bleeding from upper section, esophagus and stomach, often manifested with bloody vomiting, hematemesis. But if the vomitus reflex absent and blood go downward, you must understand before it go to the end of gastrointestinal tract, fresh blood cannot be seen because erythrocyte destroyed, and we are talking about black color feces, melena, which obligatory must be differentiated from pseudomyelena, because some patient when seen very dark feces immediately go to the doctor and inform his about bleeding, but we must ask him about some specific food which also can simulate, some medicines which can simulate dark color. But if our result of our inquiry may be characteristic for pathology of gastrointestinal tract, will obligatory send our patient on special examination to clear its true or false bleeding. We remember bleeding from upper part of gastrointestinal tract manifested with bloody vomiting, hematemesis, or specific black feces, melena. Lower section bleeding, visible because very short way for removing of blood from its source, and patient can see blood during defecation, and you understand, immediately go to the doctor. More easy see if bleeding visible as bloody vomiting or bloody defecation. If no, patient come to you with symptoms which appears due to post-hemorrhagic anemia. Patient feels weakness, anemia, giddiness, sometimes loss of consciousness, feels fear, nausea, hearing and vision problem. On examination, you pay attention on pale skin, sometimes lip cyanosis due to deficient erythrocyte and secondary hypoxia. We can see that patient can be covered with cold claim with wheat. Usually it is after first time after bleeding, it's accompanied with yawning, and we can record low blood pressure and rapid small pulse. I'll again pay your attention. There are symptoms of secondary post-hemorrhagic anemia. And in our clinical practice, we'll often meet with such group of the patient which come later after bleeding, and we must find source of bleeding depending of full inquiry, anamnesis, inspection, or some specific method examination. I'll pay your attention. Each is post-hemorrhagic anemia symptoms. Principles of diagnosis. Again, blood test. Decreased level of erythrocyte, but we must remember it's not will be immediately because our organism has some compensatory depot. But after 2-3 days, we can compare and see as level of erythrocytes and hemoglobin decreases if during this period you didn't stop source of bleeding. Then, depending of complaints, inspection, palpation, anamnesis, we'll send our patient on some instrumental examination. If stomach and esophageal, it's more easy, fibrogastroduodenoscopy. If small intestine, it's more difficult because only capsule endoscopy or double balloon endoscopy can be used. We can send our patient on X-ray examination, but it's not high diagnostic value method and may be used only if other method contraindicated. If we think about source of bleeding lower part, proctosigmoidoscopy. Some part of large intestine may be examined with colonoscopy. More problem only with small intestine, which very difficult to examine. And sometimes if the source of bleeding in pathology of the cardiovascular or some systemic disease needed more invasive method, arteriography, to reveal true origin of hemorrhagic syndrome. You see patient with bloody vomiting due to rupture of esophageal dilated vein, patient with liver cirrhosis and portal hypertension. On this slide, you see specific line rupture of the esophagus, which is characteristic for Mallory-Weiss syndrome, which often appears of the patient which abuse alcohol. Each is varicose dilated vein, esophageal vein, patient with portal hypertension. Fibrogastroscopy helps find source of bleeding into the stomach and sometimes stop it and into the duodenum. Capsule and double balloon endoscopy helps reveal pathology of small intestine, which is maybe characteristic for Crohn's disease. Proctosigmoidoscopy examines initial low part of the large intestine from rectum to descending colon, 40-50 centimeters. You also see source of bleeding. And colonoscopy, examine intestine before final part of small intestine, and sometimes maybe examine last part of the small intestine also. It depends from preparing of the patient and characteristic of apparatus. No, abdominal pain and bleeding syndrome involve all digestive system in pathological process. There are general syndrome which may be in any pathology. Dyspepsia. First of all, problem with stomach. We are talking about dyspepsia, disorderly digestive process. When the patient feel pain or discomfort in epigastric region, tightly connected with eating. Sometimes instead pain he feels feeling heaviness or overflowing of abdomen after meal, not correlated with volume of taken food, which accompanied with abdominal distension, often regurgitation or eructation, maybe nausea. All these problems appear due to decreased activity of the stomach and decreased motor function of the stomach. Food slowly digested and slowly evacuated from the stomach. As a result, patient feel these problems, which is called dyspepsia. And more correctly, when we see primary patient with these problems without full examination, our primary disease will be unspecified dyspepsia. Then we'll prescribe instrumental and some laboratory examination to differentiate each is functional or organic. If after examination, and first of all fibrogastroscopic examination, not revealed any anatomic defect of the stomach mucus, we are talking about functional dyspepsia due to disordered neuroendocrine regulation activity of the stomach. If you reveal some anatomic defect or source of inflammation or new growth, we are talking about organic dyspepsia, and instead separate pathology, dyspepsia will be syndrome of main stomach disease. What is cause of dyspeptic disorders? First of all, it is disordered secretion of gastric juice, which is poor with hydrochloric acid or with pepsin, or opposite deficiency of motilin and excessive irritation of the stomach mucus with hydrochloric acid. Other problem, motor dysfunction. Food cannot be evacuated in time due to problem with pyloric sphincter or pyloric canal. We must remember about Helicobacter pylorus infectious, which is provoke factors of inflammatory process. If it persists long time, it may be provoke factors of canceromatous process. And now we say about obligatory eradication of Helicobacter pylorus infection if it was revealed in any patient. Now I said you, if we reveal any structural modification, inflammation, peptic ulcer, new growth, we are talking about organic origin of dyspepsia. Psychological factors. More often, first of all, provoke factors of functional dyspepsia because activity of gastrointestinal tract tightly correlated with psychic appearance or psychic behavior of the patient. Later, it can provoke organic pathology, and some patient needed some correction of psychic behavior because it provokes visceral hypersensitiveness. When the some activity of the gastrointestinal tract feels of the patient as severe spastic or distensional pain and manifested with some discomfort after eating. Principles of diagnosis. Functional dyspepsia is result of excluding any organic pathology. To exclude any organic pathology or to find any anatomic defect, we'll again start from routine blood test. And we remember, for functional disorders, no any deviation from norm in laboratory and instrumental examination. We can check some biochemical tests, especially biliary tract, which can simulate dyspeptic discomfort into the stomach. We widely use respiratory tests for diagnosis Helicobacter pylorus and especially control after eradicative therapy. Fibrogastroscopy with pH metry, which examines mucus of the stomach and check its functional activity, because pH metry show activity of the stomach gland and can help you in diagnosis. We can use any test on Helicobacter pylori. It may be direct test, which exam during fibrogastroscopy, or indirect, when will reveal antibodies in the blood, in feces analysis, or any other respiratory test, laboratory test helps reveal present or absent Helicobacter pylori. And ultrasonography, if the patient feels some discomfort in abdomen, will remember about surrounding organs. And ultrasonography, biliary tract and pancreas help clear our primary diagnostic opinion. Next problem with stomach is stomach motor dysfunction. When the food difficulty or sometimes cannot be evacuated from the stomach, hold into the stomach and come back only with one way, with vomiting. We'll do differential diagnosis between pyloric stenosis, organic narrowing of pylorus, as result of post-ulcer scar, especially in pyloric part or duodenum, after chemical injury due to pathological growth of connective tissue or growth of tumor. And functional problem, abnormal spasm of pylorus, which is pathological response on active peptic ulcer, or patient with diffuse hyperacidic gastritis. Because in base of this problem is neurological disorders, and some patients without pathology of gastrointestinal tract but with severe neurosis can have some problem with digestive and cardiovascular and urinary system. Other word, food delayed into the stomach. We do differential diagnosis between functional disorders, pyloric spasm, and organic pyloric stenosis. Complaints of the patient with this syndrome. No, first of all, he feels dull, distensional pain, or usually discomfort in epigastric region after meal. Feeling heaviness and overfilling of the upper part, stomach region. Patient can see and doctor can reveal abdominal distension, especially after eating, which accompanied with active regurgitation and eructation. Patient feels nausea and it may be finished with vomiting, after which condition of the patient will be better, which show on its stomach origin. Sometimes patient can feel drought after meal, which can pay attention of the doctor on pyloric stenosis, and can lose weight, especially in pyloric stenosis, when the pyloric part completely obstructed. And you'll understand, food go only into the stomach, come back. If it's not go out from the stomach, impossible its absorption, and patient after some time progressively loses weight. For diagnosis, first of all, we'll pay attention on general condition of the patient and especially inspection of the stomach and palpation, during which we can reveal specific drop symptoms. Because if the food holds into the stomach during palpation, it moves and then we can listen as it again falls from upper to lower part. X-ray examination has high diagnostic value because patient swallows barium and you can easily see on what level barium stopped or slightly or partially evacuated and after what times. We'll send the patient on gastroduodenoscopy to reveal source of this problem, take biopsy and decide question about next hour treatment. On X-ray examination, you see narrowing of the pylorus due to growth of tumor, which shows why patient has some problem and indicates about organic pathology. Next syndrome appears of the patient with pathology of large intestine. We are talking about irritative bowel syndrome, which is functional disease. And it's characterized with abdominal pain and disordered defecation, predilection to constipation or diarrhea, or they may alter. When we are talking about abdominal pain, it must be not less than 1 time per week during 3 months and not less than 6 months before doctor examination. Again, I'll pay your attention. We are talking about irritative bowel syndrome. When the patient comes to you with abdominal pain, which appears not less than 1 time per week during 3 months and nearly 6 months before examination. It's accompanied with disordered defecation. Patient can feel spallation after defecation. Pain appears together with defecation rate, and obligatory will be change characteristic of feces, the shape and consistency. Because depending on shape and consistency of the feces, we can say about constipation or diarrhea. And I'll pay your attention. Irritative bowel syndrome, functional disease, and patient feels pain, but this pain whenever disturb his sleep. If the pain appears during night and disturbs sleep of the patient, it cannot be irritative bowel syndrome. We must find any organic pathology of intestine. I said your abdominal pain obligatory oftenly accompanied with disordered defecation. And will obligatory ask the patient about time of defecation. It may be rare or often. We'll ask him about consistency of the feces, which may be hard or liquid or completely watery. We ask him about direction of defecation, how long time needed for effective defecation. Accompanied it with excessive effort, feel the patient incomplete evacuation of feces after defecation, or opposite, sudden desire on defecation sometimes cannot be prevented. And depending on his answer, will approximately formulate primary opinion. We are talking about constipation. If the defecation rare with hard feces and needed lot of time, sometimes discomfort. We are talking about diarrhea when the defecation is often, feces liquid, and sometimes accompanied with sudden desire on defecation. More full information about constipation and diarrhea we can take from Bristol scales, about which I'll stop later. But I want to say you about auxiliary symptoms characteristic for irritative bowel syndrome, because two main symptoms, pain and disordered defecation, but it can accompany it with increased secretion of mucus, with abdomen swelling, feeling rumbling in the abdomen, especially for the patient with diarrhea, and clinical picture is very rich with psychogenic symptoms or symptoms vegetative disorders, and will obligatory completely ask the patient to reveal some symptoms other functional gastrointestinal tract diseases, and more often irritative bowel syndrome are combined with stomach dyspepsia, about which we said later, because we remember about disordered digestion and evacuation of food. Etiology, irritative bowel syndrome. First of all, motor dysfunction, slow passage of chymus, more hard feces, difficult evacuation, pain in abdomen, constipation. Fast motility of intestine, liquid feces, diarrhea, sometimes accompanied with spasm, again pain in abdomen. We must remember about spontanetic sensibility disturbances. I said you when the patient some impulse feels more intensively, and which known for a lot of people may be painful for this group of patients. Irritative bowel syndrome tightly connected with activity central nervous system, and now we said about main pathogenic mechanism between brain and intestine. We must remember about psychopathologic disturbances, because activity of gastrointestinal motor function tightly correlated with psychic behavior of patient. Irritative bowel syndrome appears as complication post-infectious intestine inflammation. We release pathological factors. We'll come back microbiota of intestine, but complete comeback of motor activity and functional activity of large intestine needed more lot time, and no anatomic problem, but present some functional disorders. We must remember about some allergic agent which may be stimulate the factors of irritative disorders. because our food sometimes may be allergic and will prescribe specific examination of the patient HEMA test, which can reveal some allergic agent on some food and give true dietary recommendation. And external or internal trigger factors, which provokes appearance or gravity of the irritative bowel syndrome. Any stress, any preceded dysbacteriosis from which patient took some treatment. And we must remember about our food, which is very rich with antibiotic. Clinical classification. Irritative bowel syndrome depends from characteristic of feces. I said you about Bristol scale, and on this picture you see character of the feces. Each is known when the feces is soft and resembles sausage. You see feces fragmented on some portions. Ball-like feces becomes hard, which is characteristic for constipation, and then consistency of the feces becomes more liquid and sometimes completely watery, which is characteristic for diarrhea. And if the patient complains of hard, rare, difficult defecation, will give conclusion about irritative bowel syndrome with constipation. You understand opposite characteristic, irritative bowel syndrome with diarrhea. But often we'll meet with changing constipation and diarrhea. We are talking about irritative bowel syndrome mixed. But irritative bowel syndrome is functional disease, which may be possible only if no symptoms of any organic pathology. And I'll again remember you about red flag symptom, especially for the patient with after 50 years old, because functional disorders often appear in younger people. Senile people, first of all, predilected to any organic pathology. And to exclude loss of any growth diseases, especially growth of tumor, we must remember about dangerous or red flag symptoms. First of all, functional disorders whenever accompanied with loss of weight. I remember you, no night pain, abdominal pain not constant. I said you about age of patient and compromised history. If the mother or father, your patient, had in anamnesis canceromatous pathology, will obligatory examine this group of patients completely to exclude organic pathology. Only after that we can say about irritative bowel syndrome. I said you usual gastroenterological pathology, especially functional disorders, whenever accompanied with fever and palpation of abdomen, completely there is no, maybe some discomfort, but characteristic of part of intestine and must be there is no. And laboratory examination, any deviation from norm in analysis, or if the patient show blood in feces and when will reveal blood in feces, it's completely exclude functional disease. It may be only organic pathology, inflammatory diseases of the intestine such as specific, non-specific colitis, Crohn's disease, and others. Principles of diagnostics. Based on the Roman criteria, fourth correction, which was made 2016 years, and characteristic of feces dependent Bristol scale. And if we not revealed any provoke factors about which I said you up, your disease may be irritative bowel syndrome. But it may be without any specific examination for the younger patient, will orient it on duration of disease and time between consultation. Will remember pain one time per week during 3 months and not less than 6 months before examination, which indicate about its chronic development. If you have any confusion, we'll examine our patient more completely, and first of all we'll use blood and urinary analysis, some biochemical tests which helps reveal inflammatory process, and analysis of feces, first of all on deep-seated blood. Additional method examination is instrumental colonoscopy, proctosigmoidoscopy, or bowel X-ray examination. But I said you, if no provoke factors, you can establish, and younger age of the patient, we can diagnose this irritative bowel syndrome without specific instrumental and laboratory examination. You see, a spasm of intestine provoke formation bulk-like feces. And you see on X-ray examination will reveal defect filling of intestine with barium, which exclude functional disorder because it's new growth. Same picture you see this X-ray examination. You see defect of the intestine filling. Same result on X-ray examination with high diagnostic value for revealing of tumor. Colonoscopy helps assess mucus and, if needed, take biopsy to clear disease, which is normal mucus and affected mucus. You see it becomes more red with some defect and sometimes can find source of bleeding. And last syndrome on which I want to stop today, it is malabsorption syndrome, which is characteristic for pathology of small intestine, because absorption of the food is possible only into the small intestine due to its specific anatomic structure, presence of village. And when we think about malabsorption syndrome, first of all, we must exclude pathology of small intestine, resection of the intestine in anamnesis, 60 centimeters of the small intestine which was resected. For example, patients with Crohn's disease, with growth of tumor, may be complicated on all next life with malabsorption. Crohn's disease, Whipple disease, celiac disease, or gluten enteropathy, more often pathology which accompanied with malabsorption. We must remember about microbiota, and you must know that microorganisms which live in small and large intestine different. And intestinal dysbacteriosis sometimes is severe provoke factors of malabsorption. We must remember about possible deficiency small intestine enzymes, because it's from their activity depends microdigestion and then absorption, which impossible without final microdigestion. Rare case, but we maybe, and we must know about it, small intestine circulatory injury. No, it's atherosclerotic affection of the intestinal vessels, mesenterial vessel. And next problem, it is problem with pancreas. And when we talk with you about differential diagnosis between malabsorption in feces analysis. We said with you between differential diagnosis of small intestine enteritis and excretory pancreatic insufficiency, because to adequate absorption, food must be digested into the duodenum, macrodigesting, then final microdigesting in small intestine due to activity of village, and then adequate absorption of digested element of food. Clinical signs malabsorption. First of all, patient complains of diarrhea. And from last lecture, we remember diarrhea may be both small and large intestine origin. To differentiate, we'll ask the patient about time and amount of evacuated liquid feces. If the diarrhea appears only after eating and accompanied with a lot amount of liquid feces, it is more characteristic for small intestine diarrhea, maybe due to malabsorption. If the often defecation with small portion of feces, it's more characteristic for large intestine diarrhea, and we must find problem in absorption of water and motor dysfunction of large intestine, maybe irritative bowel syndrome. Weight loss. Often signs of malabsorption, because you understand, if no absorption of food, no microelements, no definite level of carbohydrate, fat and protein in our organism. As a result, patient progressively loses weight. And asthenic syndrome, decreased vital activity. You'll understand, patient becomes weak. His vital activity and work capacity decreases. He loses interest to surroundings, loses appetite, and all other signs which characterize our vital activity. Now, finally, if malabsorption not corrected in time, later we'll see patient with heavy metabolic disturbances. No? For example, this patient which you see on this slide. What metabolic disturbances may be revealed? No, you understand. No increased source of energy because deficiency of carbohydrate, decreased working activity, no definite level of protein, fat, vitamins and microelements. We remember vitamin and microelements are coenzymes. If no definite enzymes, impossible any adequate metabolic process. There are severe problems of which is grave complication of malabsorption, and if we see patient on the stage of metabolic disorders, you understand a difficulty come back activity of his organ and organism to normal active life. Because visible side indicates about deficiency of deposited elements, macro and micro elements, and it's come back to norm very slowly and difficulty. Now, if we are talking about disordered fat metabolism, first of all, we'll see deficiency of weight. In analysis, will reveal hypercholesterolemia. Will be decreased level of liposoluble vitamin. First of all, vitamin D, K, E, A, and maybe due to disordered fat metabolism and abnormal metabolism, fat metabolism into the liver, will be formed fatty hepatosis. First of all, we diagnose fatty hepatosis of the patient with obesity, but we must remember that hepatosis is result disordered liver fat metabolism, which may be both increased or decreased weight of the patient. Carbohydrate absorption manifested with hypoglycemia. We know that carbohydrate is source of energy, and disturbance of carbohydrate metabolism clinically manifested with progressive weakness and decreased work activity. Protein metabolism manifested with hypoproteinemia, and first of all, level of albumin in blood decreases. From physiology, you know, albumin is needed to hold blood into the vessel due to control oncotic pressure. If no oncotic pressure, blood cannot be held inside the vessels, pleasant, easy absorption surrounded, and with a patient with hyperproteinemic edema, which start first of all from lower parts of the body. Solid becomes edematous, later it moves upward, and in heavy cases we can see patients with heavy edema, which very difficulty relief, because for hyperproteinemic edema impossible to use diuretic medicines. Water-salt balance also disturbed. First of all, due to deficiency of some microelement will reveal hypokalemia, deficiency of potassium, hyponatremia, deficiency of sodium, hypocalcemia. You know there are main microelements for activity of cardiovascular system. If you remember our fourth lecture about recording ACG, I said you that activity of the heart tightly correlated with activity of such microelements as sodium, potassium, chloride, calcium. And clinically, patients come to you or in cardiovascular department with different types of arrhythmias. It may be extrasystole, it may be attacks of paroxysmal tachycardia, and then other more heavy disorders of cardiac rhythm and rate. We must remember about deficient phosphorus together with hypocalcemia, hypophosphatemia, manifested with different disorders of nervous system, predilection to paresthesia, and sometimes different cramps, and maybe problem with skeleton of the patient, because calcium and phosphorus are main structural elements of the bone, and they deficient patient predilected to easy fractures of the bone. Iron deficiency, clinically manifested with iron deficiency anemia, which explain why patients such weak, disturbed sleep, and decreased vital activity, and deficiency of iron also progressively disturbed activity of cardiovascular system. Patient feels weakness in muscular system, because we remember about function of iron not only for hematopoiesis, it's needed for normal tissue breathing, and it's included in some enzymes. Vitamin disbalance manifested with polyhypovitaminosis, and first of all, B12 deficiency manifested with B12 deficiency anemia, which affect mucus of oral cavity. Patient feels problem with toes and gums. If it's complicated with iron deficiency, more intensive caries and why doctors of hospitalization and stomatological physician might remember if one patient come to him oftenly and result of his treatment not effective, obligatory needed control blood analysis to reveal uh, iron or B12 deficiency anemia. We can see fissures in the mouth angle due to deficiency of vitamin PP and C. We remember that vitamin D needed for normal structure of bone together with activity of calcium and phosphorus. Activity of some vitamins tightly correlated with some microelement and all process in our organism tightly correlated. You see pellagrose glossitis, which is characteristic with bright red tongue and fissures in angle mouth, which is characteristic for deficiency vitamin PP. Atrophic glossitis, which is visited cut or progressive vitamin B12 deficiency. We can see problem with hair, which also result deficiency of the iron, vitamin B12. We see specific formation of nails, spoon-like nail, deformation of nail, and you see they can hold drops of water. It's also visited cut progressive iron deficiency anemia and it's siderapenic syndrome. Heavy degree of malabsorption manifested with affection of skin, dirty hyperkeratosis, pellagra, eczema, neurodermatitis. And sometimes patients accept gastroenterological or therapeutic department, go in specific skin department. Why we say you that and in many countries first visited to the doctor must start from therapeutic physician, which decide due to deep differential diagnosis, each is true therapeutic pathology, needed patient in consultation of other doctor, or first of all, we must correct primary therapeutic pathology, pathology of inner organs. Heavy degree of malabsorption reached with neurologic syndrome. I said you about polyneuritis due to deficiency of vitamin group B, calcium, potassium, magnesium. Patient related to convulsion due to deficiency of magnesium and calcium. And as a result, progressive encephalopathy, psychic disorders. We reveal some non-adequate psychic behavior because anemia, because decreased metabolic activity, deficiency of carbohydrate, fat, protein, all these elements needed for a normal activity of central nervous system. Deficiency of fat metabolism and first of all hypercholesterolemia manifested with depression of endocrine gland functions because activity of endocrine enzyme synthesis tightly correlated with level of cholesterol. And we can reveal some problem with adrenal gland, hyperadrenal pituitary insufficiency, and hypothyroidism. You see patient with keratosis and eczema, which is keratosis, and pellagra, specific disordered skin pigmentation. You see patients with different disorders of gait due to neuropathy, due to deficiency of vitamin group B, first of all, and such microelement as calcium, potassium, magnesium. Principles of diagnosis. No, we'll again first of all start from routine blood test, which shows any types of anemia. Obligatory biochemical test will completely examine all metabolism to know what metabolism first of all needed our correction due to active parenteral nutrition, because no other way if the intake food cannot be absorbed adequately. We'll examine level of vitamins, level of microelements, protein, fat, blood sugar. Feces analysis helps you in diagnosis because you can see that feces will be rich with remnants of undigested food. We are talking about creatorrhea, amyloria, and steatorrhea. Will prescribe test with deoxylose to exclude celiakia or galactose insufficiency. We'll send our patient on hydrogenous respiratory test to reveal problem with small intestine and syndrome of excessive bacterial growth into the small intestine, which may be provoked factors of malabsorption and needed emergency correction. We can prescribe double balloon or capsular endoscopy because we remember sort of malabsorption into the small intestine. And we need it clear what problems with small intestine. It's inflammations, non-specific, specific. It's anatomic defect or some new growth. And if possible, we can take small intestine biopsy, but more often it is possible only during surgical correction. When the patient enters in a hospital with acute abdomen due to rupture of small intestine and peritonitis due to progressive Crohn's diseases or new growth, and we can clear primary disease, but it will be late, and you'll understand that more late diagnosis some or other pathologies, and more difficulty and longer, more time needed for correction, and sometimes adequate correction becomes impossible. Thank you so much for your attention. I think it helps you to prepare for practical classes and exam, because on exam all these questions will be included in exam task. Be healthy, we'll meet with you next week. Goodbye.